Hi, I'm Dr. Zandra Petway, and you're watching Dr. Petway and Friends. And today, my very special friend is Dr. David Horowitz. Hello, Dr. Horowitz. How are you today?
I'm doing well, thank you.
Great. Dr. Horowitz is a dermatologist, and he's here to talk to us about the skin. So tell us about some of the different types of patients that you see in your practice.
Well, we are dermatology, which is skin, hair, and nails.
Okay.
And dermatology is like general practice in a sense because we see children, babies, from a day old to centurions.
Okay.
And obviously males, females. You know, and where we are downtown, all races, Asians, Hispanics, black and white. Okay. So we, it depends when you say what do we see. It depends on sort of on the age group. Okay. And the kids, they have, a lot of have angiomas. They have warts. They have viral diseases. They have molluscum. Okay. They have eczema. They have such as atopic dermatitis. Okay. They have just so many different things. There's 2,400 separate diagnostic codes in dermatology.
Wow, and you see them all.
Yeah, we see them all with athletics. They get the legendary jock itch. They get athlete's foot. They get molluscum. They get warts. They get herpes. Okay. Multiple different conditions, eczemas. Okay. The adults, when they're young, get many of the same things. When they get older, they start to have the skin changes of chronic sun exposure, where they see various types of keratosis, actinic and seborrheic keratosis. Okay. They have basal cells, squamous cells, occasionally melanomas. They have solar elastosis, brown spots, gray spots, white spots, yellow spots, spots of all sizes and shapes. Oh, okay. And, as we know on our planet, there are multiple colors of skin, from pale Scandinavians to the blue-black color of a Nigerian. Okay. But whatever color you are, whether it's the whitest of white or the darkest of dark, you always want it to be all the same color. Of course. You don't like white spots on dark skin or dark spots on white skin and red spots on white skin because there's not much pigment. So we also deal with dyschromias. Okay. Many, the conditions that change color. Okay. We also deal with all sorts of nail problems, again, from fungus to psoriasis to lichen planus to contact dermatitis. Okay. And we deal with hair problems, too much hair, not enough hair, always something with the hair. Okay. So what would you say you see the most of? Probably acne, warts, and eczema. Okay, well, let's talk a little bit about that. Tell us about the different types of acne. Well, you have three kinds: mild, moderate, and severe. Okay. You have the acne that acne is a polymorphous eruption. Okay. You have many different kinds of lesions. You have papules, which are little red bumps. Okay. You have pustules, where that little red bump has a little pus pocket on the top. Okay. You have comedoes, open or closed comedoes, and an open comedose is known as a blackhead, and a closed comedose is known as a whitehead. Okay. And then you have the larger lesions called nodules, and then you have the really large lesions called cysts, and then you have the tunneling of the cysts that when you have acne, severe acne, acne conglobata, that's what they call it, very bad acne. Nodulocystic acne. And they're treated various ways. They're treated mostly with topical and systemic medications of varying sorts. The topicals are traditionally either an antibiotic, and nowadays mostly clindamycin. And they also benzoyl peroxide is used topically, and the retinoids. And there's retinoic acid, retinaldehyde, and retinoids. Three different ones. And two are prescription. The retinaldehyde, when it came out, was the weak sister. But now you can find that over the counter also if you look hard enough for it. So that's changed a little bit. Also with acne, we have systemic antibiotics, most common being doxycycline, tetracycline, minocycline, occasionally sulfur drugs. And for the most refractory, we have Accutane still, which is a terribly controversial drug. And probably the best thing to ever happen to acne in the last couple thousand years. And now is heavily restricted by the government because of the problems with the pregnancies. With acne requiring Accutane, it's a teratogenic medication. So you have to be very careful to explain to the patients in great detail. They simply cannot, not that they can't have sex, they just can't have acne. I mean, can't have
the Accutane.
They can't take Accutane if they're not going to take some form of birth control.
Okay, and tell us what teratogenic means.
Teratogenic means you'll have an abnormal baby. Okay. It will have many times something wrong, short arms, sometimes mental retardation, other kinds of problems that can be lifelong in nature. So it's just much easier, to just not get pregnant while you're taking the course of Accutane, and for not more than 60, 90 days afterwards, to be even safer. Okay. But it can fix the unfixable. I mean, it's just a wonderful, wonderful medication.
Well, does it affect the sperm as well? So should the man not take it, or just the women?
The man can. There's not been. That's a good question. But the men we find stay active, and if they get an individual pregnant, we don't see much of a problem.
So it's mainly when the women take the Accutane.
Yeah, it's usually for the female. That she has to be aware of the teratogenic problems.
Alrighty, what about things like facials? Do they help acne? Or skin peels?
If you get peels, P-E-E-L-S, often understood when people say, and in the South, if they say pills or peels, it's sometimes hard to tell the difference. With peels, yes, if you use a salicylic acid peel or a glycolic acid peel, then you can get some benefit with the acne, in addition to using, not in lieu of, but in addition to using the other more traditional products.
And do you offer that at your office?
We do.
Well, good. So you said the treatment consists of topical antibiotics, oral antibiotics.
But not usually at the same individual. If you're going to go topical, you use three things mostly: benzoyl peroxides. You use topical antibiotics. Leader this day and time is Cleocin and the retinoid. The most common that people seem to know is Retin A. Dapoline is another one that's out there. But they're one of each three categories. Is probably what you're going to use if you're going to go in a strong topical only regimen. For some people who don't want to, or for some medical reason can't take PO meds.
All right. And if you decide to go oral antibiotics, is it oral antibiotics only? Or topical in addition? You say you just go one route?
Usually would go one. So you would use the retinoids topically, you would use your benzoyl peroxides topically. Occasionally now, there's a medicine out called Axone, which is topical Dapsone. And that can be used topically. But you would not necessarily need topical Cleocin if you were going to be using a systemic antibiotic.
Great. So you say you also see a lot of warts in your office?
Warts in all sorts of locations.
Well, tell us about the warts.
Well, you see warts on the scalp, you see warts on the face, you see warts on the eyelids, you see warts in the nose, you see warts on the tongue, you see warts on the labia, on the lips, on the mouth, on the neck. For women, you can even see warts on the breast, they can see it on the men's genitalia. And you can see it periungually around the nails, which are often very difficult to treat. They can be on the palmar surface. They can be on the plantar surface. And warts remain after 4,000 years still a very difficult problem to treat. Selected warts, mostly palmoplantar and periungual, are very difficult. And then it depends on age. Because any wart in 4, 5, 6 years old is difficult because they're panicked anyway. They reach that point in life where they can scream very loudly and can be heard throughout the entire office, even when you walk into the room, much less when you try to start treatment. So often there are topicals that you use when you just can't use mechanical ways to try to fix it.
So what do you do mostly to fix a wart?
Well, our favorite remains cryosurgery.
Okay.
I mean, it's a strong favorite because all the other methods are only when cryosurgery doesn't work. Sometimes on the plantar or palmar surface we use duct tape, we use salicylic acid pads. You can also numb the lesions up with anesthetic, use electrodesiccation. You'll read a lot about lasers in warts, but we find that when you do that, the charring from the laser sometimes make you use your outline, your boundaries, and it gets to be somewhat difficult. So I don't do that much anymore. I did a lot when the lasers first came out because they were purported to be a panacea. You know, this was the home run. And it wasn't. The morbidity was reasonable. They would hurt for longer afterwards than the other treatments. And there was the same level of recurrence. And because of the cost of the lasers, often the cost was much higher. So, you know, right now, unless somebody, you know, has become very adept at it, it's not always, you know, what it was once hoped to be.
And tell our viewers, how do people contract warts?
Warts are viruses. They're parvovirus, and you usually get it by human contact. Holding hands, smooching, you know, or wrestling. We see you know, it's funny with, we used to do, I guess, yearly physicals for the wrestlers. Because wrestlers of all the sports get more contact with their opponents, and you can see all sorts of, you know, conditions transmitted from wrestler to wrestler. So almost every wrestling team has to have a doc, you know, constantly watching them. They get ringworms, they get molluscum, you know, they get warts, they get other viruses, and, you know, fungus infection.
Wow. Tell us a little bit about molluscum. What exactly is that?
Molluscum contagiosum is a pox virus. And it looks like little acne lesions sometimes, but they're very uniform, and there can be anywhere from 1 to 100. Occasionally they bury under the skin and you get a red nodule, and it's an unusual looking thing. When you biopsy, you're always surprised when it's a buried molluscum. Because they're usually superficial, and you enucleate the center and you can get them better. But again, they can come in such profusion, they can be in anatomically sensitive areas, and they come at the worst ages for us because they're those kids that just are not very amenable to any of the more aggressive, quick fixable treatments. You know, you almost have to get the parents involved with topicals that have to be meticulously applied to each individual lesion, and there are many. And then you hope that Mother Nature kicks in somewhere along the line.
What are some of the topicals that you use for that?
Well, we use DCA sometimes. We'll use retinoic acid. It's one of the main ones we use. Some people use a little TCA. Cantharidin is used by some. We have to put a drop on it. And the hard part is when you tell a parent to put a drop on a tiny lesion, always a fair amount gets on the little circle around the lesion. You know, the immediate adjacent skin. And when that often causes a much larger reaction than intended, because the medicine is made to be applied only with maybe a fine wooden toothpick, where you would just place it on the tip of the elevated part of the lesion. And that's all you want, but people always think more is better, so they put a big drop on it and leaks down the side, and now you've got this halo and a larger inflammation. And these kids are often with fair skin, and they're 4 years old or 6 years old, and they get a pretty rip-roaring reaction, and it leaves a dyschromic. Again, we get back to the discoloration. You know, a discolored spot, if it's in a white child, it'll be a red-purple spot, and if it's a black child, it'll be a brown spot darker than their surrounding skin color. You know, the regular skin color.
Tell us a little bit about eczema. You said that's something that you see a lot of?
Eczema we see a lot of. There's all forms of eczema. One of the most common forms of eczema is seborrheic eczema, seborrheic dermatitis. We see that in everybody. You know. from the infants, which is diaper rash and the cradle cap, to seniors, especially if they have Parkinson's or some of the neurologic diseases where they get just severe psoriasis and seborrhea on the scalp.
Okay.
They also, we see psoriasis on the scalp also, speaking of scalps.
How can you tell the difference?
And a lot of times you can't. That, psoriasis is like on a spectrum. And there are times when psoriasis and seborrhea look identical, not only to the clinician, but even if you biopsy it, you might get a readout such as a psoriasiform dermatitis or eczematous psoriasis, which tells you that certain components of the biopsy look like psoriasis and others look like eczema, almost like a mongrel dog, and that's called sebopsoriasis.
Okay.
And that's usually always in the scalp with the thick yellowish to red scaly plaques. And psoriasis can show up also on the eyebrows, on the nasolabial folds, in the ears, around here, and men often in the mid-chest area, men and women in the axilla under the arms and the groin.
Okay.
And then we see atopic eczema, as you know, is in the bends of the arms and the back of the legs, and the back of the neck, and wrists. And that's often associated with asthma and hay fever, when they have atopic diathesis. We see contact dermatitis. The two most common are nickel, where you get the darkening or the reddening and induration of the earlobes from the old earrings. Not as much now as they learn about that. Also, you get poison ivy, which is this time of year we see all the time. It's just red, scaly, stubborn rashes that itch intensely, keep people up at night.
And what do you normally do for poison ivy?
Poison ivy depends how aggressive it is, depends, if they've had it before, and what their experience has been with it before. If it's 2 spots on this arm and it's poison ivy and it's been 3 days and it's not spreading, they'll probably get just topicals. If they say, "Doc, I've been here before, it's about ready to blow," then we often give them systemic steroids along with topical steroids and some antihistamine to try to stop the itching.
Okay. And what about, back to the eczema, how do you treat that? Like the atopic eczema?
The same thing.
The steroid
we
creams?
also use, we have soapless cleansers now that have no preservatives, they have no fragrance, and they will clean you. They have very few surfactants. And as you know, surfactants cause bubbles. When you see those pretty, those pictures, not pictures, but advertisements on TV of these luxurious bubble baths, all those bubbles are surfactants.
Okay.
And when you use Palmolive dishwashing, all those bubbles are surfactants, or Prel shampoo, all of them.
Right.
And surfactants are great, except that they're very bad for eczema. They further irritate eczema.
Okay.
So you wash with that, and now we're using these newer, some newer topicals, topical creams. And for example, on our skin is something called a biofilm. And the biofilm is the last interface between our skin and the air. Sort of like the shingle is the last interface between a house and the air. Well, the biofilm is made up mostly of lipids. And it's 70% ceramide, and the other 30% is about equal between essential fatty acids and cholesterol. Well, so many of the creams and lotions that everybody uses has none of the above in it. They've just got other ingredients that take the place of those 3. But now there are creams out there. There's one called CeraVe that's over the counter that has Cera for the ceramides, that's 70% component, and then it also has the essential fatty acids and the cholesterol. So when you replace it, it's more physiologic than anything else out there at this point in time. Cetaphil is working to get one of those, but those same ingredients Lubriderm doesn't have, Neutrogena doesn't have quite yet, but they're probably also working on it. It's going to be a new wave in topical. And the beautiful thing about it is that it's not very expensive. Anything you can buy over the counter is often much cheaper. And this is cheap, $15, $20 for a large container. So, That's important because, as you well know, with the cost of medicines going up today, one of the problems we have in dermatology, like everywhere else, is just simply cost of the medicines. It's not good enough to come up with the correct diagnosis and come up with the correct treatments for that diagnosis. You've got to know how much that patient, how much they have in their pockets to pay for the medicine. If I write 4 scripts and it's $200, and I don't ask the patient, they get to the pharmacy, they have, you know, sticker shock, and they go, I don't have that, and they walk away and they get none of it.
You know, actually you treat my son for acne, and you wrote him a prescription medicine, and I took it to the pharmacist, and I could see that he has Blue Cross Blue Shield insurance. I could see the price upside down. I said, excuse me, does that say $700?
That's right, and you got it for that's because of the insurance.
Well, no, they said insurance didn't cover it, and we had to pay $700. I said, I don't think he needs the acne medicine that costs $700. And then I think what happened, he told me that you had given him a coupon to get it for free, so we got it for free. But when I saw the $700, like, no, he does not need an acne medicine that costs $700.
It's just never talked about. But the real, you know, well, the problem, some of the docs just give the script and walk out of the room. What you've got to do, then we say, you know, that same patient, you have $100. And they say, no, so you got $25 to put, what can you really put down on medicine? And if they say yes, then I'll change, but I can get them better for $25. It may not be space age stuff, but it's decent stuff. And so, you know, it's something that's factoring more and more into how all of us practice medicine now. Is not just the right medication. It's, you know, can that patient afford it? And you have to know that. If you're a good doc, you just got to know that. Other thing that we see a lot of that you mentioned is hair loss. You know, we have, I don't know who's more miserable, the PCOS, you know, polycystic ovary disease with too much hair, or women from 25 to 95 who are losing their hair for various reasons, either androgenetic alopecia or follicular degeneration syndrome, or alopecia areata, or thyroid disease, or you know, chemo, or traction alopecia from the you know, the 4 horsemen of the apocalypse in the black community is perm, press, hot comb, and relax, because they make you gorgeous, but they take a toll on the hair over time. You know, and I just think how limited it was, you know, 80 years ago in the community. And now these geniuses can do all sorts of things, living proof of your style today. And because the the hairdressers have become so good, the stylists, that almost everybody gets one of those 4 entities done, and they look great. And because they look great, it's like an addiction. They don't want to give it up, and therefore they're very reticent to let go of the 4 horsemen. And eventually they have to, because the damage, you know, starts to get where they can't conceal it, they can't hide it, they don't necessarily want to go to wigs, and they can't necessarily afford wigs, and the ones they can afford are not the best.
But what do you do for a person who has hair loss?
Well,
like my
hair
mother.
loss is very generic. It's like somebody with a headache. You know, first of all, we have to know. We have to know what medications they're on, because there's many medications now that can cause hair loss. Those you have to know about. You have to know if their kidneys are okay, liver's okay. I mean, there's a lot of chronic illnesses that can, like lupus, you know, you have to do an ANA sometimes to find out if, because discoid lupus can show up on the scalp, and so can SLE. So you have to do a battery of that. Often we do a hair pull. Then we have to do a microscopic hair exam. Where
what are you looking for when you do that? When you're looking at the hair in the microscope, what are you looking for?
Well, number one, to see if they have Pili torti, or monolithrix, or Trichorexis nodosa, or, you know, Fragilistus crinum. All these little things you look for in the hair shaft that are signs of too much combing, or you know, that 20 combs a day. That's, you know, an urban legend is sometimes not always the best thing to do if your hair is curly, because it jerks it. So then we do that. Sometimes we're forced to do biopsies, you know, if we're not finding it.
Okay.
And then we do, with the biopsies, we do horizontal and vertical cuts to do different, studies there. And once all that's put together, then we try to come up with a diagnosis and a treatment plan. But it takes 2 or 3 visits. It's not just, oh, by the way, as they're leaving, they'll ask 14 other skin questions because everybody comes with a list.
Right.
And then they'll ask you, oh, by the way, my hair's falling out. Or just like if they're leaving you, so, by the way, I'm dizzy. And you know what that means. I mean, certain chief complaints engender a lot more time than you've got when your mind is set that the patient's time is up.
Yeah.
And there's a handful of those you just don't want to hear. Is that, by the way?
Yeah. So then, what do you
dreaded,
do?
Oh, by the way. Well, what we try to do then, if it's hair, again, we'll still try to at least give them an order sheet for all the lab tests.
Right, okay.
And again, what we do is we often ask if they had any lab tests last couple of months, and they'll say, oh yes, my internist checked me for hair loss.
Okay.
And we've learned that the testing that the internist does for hair loss is often a little bit different. There's some overlap, usually with thyroid, but there's other tests that we do that they don't.
Okay.
The antimicrosomal antibodies, we do ferritin levels, and rarely do the internists do that, or the OB, or any of the other docs that tend to hair. And they usually, they'll do, usually the workup for hair is they'll do 1 or 2 tests, and if they're not, they throw up their hands because they've already spent all the time on the diabetes and obesity, thyroid problems. Okay.
Well, what role does vitamins play with hair? Because I see vitamins over the counter that say vitamins for hair, skin, and nails.
Vitamins are almost like with everybody else. A vitamin, if you need a regular vitamin, that's okay. There are hair vitamins where what they do is they break down a hair and see what the components are. But even if you mimic those components in a vitamin, it doesn't necessarily make hair grow. It may give you a little better shot of maintaining what you got. The thing we recommend most is biotin, but only a certain kind, because there's so many biotins out there. And
which kind do you recommend?
Well,
because I take biotin. Make sure I'm taking the right one.
It's 2,400 units.
Okay.
And
I take 5,000.
Well, that's. But it depends. Then there's other variations. Okay. But biotin is one of the strongest because it's good for hair and nails. And it's that's the one thing we recommend. Occasionally, most people are on a vitamin anyway. We see very few, actually, that aren't.
Okay. Okay. Well, it looks like we're about out of time. Such an interesting discussion. We could go on and on, especially when it comes to hair and vitamins, etc.
I mean, it's just warm up. And the one you want to know is a Pyrex.
Okay.
APPEREX.